Hello, Larry. How you doing?
Great, Glenn. Great to be with you.
Indeed, and I am glad to be talking to you. This is Glenn Loury, the Glenn Show at bloggingheads.tv. Welcome to the Glenn Show at bloggingheads.tv. I'm here with Laurence Kotlikoff, who is professor of economics at Boston University and is my old friend, was best man at my wedding. Is one of the smartest economists that I know, and is a frequent guest on the Glenn Show. We count them up. They number in the dozens or something of the times that you have been a guest on the Glenn Show. So it's like he's a contributing editor to the Glenn Show on matters of economic significance, authored many books and whatnot. Larry, welcome to the Glenn Show.
Thanks for that lovely introduction. It's overly generous, and it's great to be with you.
I should mention that the Watson Institute, who employ me, sponsors the Glenn Show at bloggingheads.tv. That's the Watson Institute for International Public Affairs at Brown University. So, topic of the day, Larry, is economics. What do smart economists, we're going to pat ourselves on the back and call ourselves smart economists, have to say about the economics of the COVID-19 crisis, the pandemic, and reaction to it and whatnot. And you've been writing pieces and publishing them in your various venues, and they can all be found at kotlikoff.net. Did I get that correct?
Right, exactly.
On the importance of testing, on the possibility of a universality of testing, on how testing information might be used, of what the incentives are in the context of people getting this kind of information. This is a classic economics of information kind of problem. Because you want people to identify whether or not they have the virus. You want to be able to monitor the spread of it. You want to be able to engage in commerce while keeping people safe and stuff like that. So that's sort of like one aspect of the economics of COVID-19 that I think we could discuss: testing the information it generates, how the market makes use of that information, what the incentives are. And another aspect of it, I think, is that, the relief questions that are raised by the big hit that the economy is taking from shutdown and I don't know. I don't even know how to begin to describe the transformations that are going on. Anyway, I don't want to talk on too long. Just want to sort of set the stage, economics of COVID-19, two economists commiserating. What do you think?
Well, I think, let me go back to where I first started thinking about this crisis back in late March. The first article I wrote about COVID testing said, and I didn't know how we could actually achieve this, but I said, well, we need to do the optimal solution is to test everybody every day. Because if you test everybody every day, you find out when the virus hits. As soon as somebody becomes infectious, whether or not they're symptomatic, you keep them in quarantine, and now you've captured the virus. This is a strategy for capturing any epidemic and killing it, any virus.
Is it feasible?
Is it feasible? Well, then I started thinking about how to do it, and I got an email from two economists in France, one at Toulouse, Christian Gaulier, who you know, and it was about group testing. And they referred to a study that Robert Dorfman, a professor who was at Harvard when I was at Harvard.
The late, great Bob Dorfman. Dorfman, Samuelson, and Solo. I cut my teeth on that book.
Linear programming, yeah. So Dorfman was assigned in the 40s before, I don't know whether he was an economist yet or what. Anyway, he was in the military, and they assigned him to figure out how to test troops for syphilis, new recruits. And doing each syphilis test individually was very expensive. So he decided to take blood from 50 people at a time, 50 recruits at a time, put it all together in one bucket and test the bucket, test the entire batch. That's called group testing or pool testing. So if that's negative, that entire batch of blood is negative, then you can free 50 people. You can say, okay, you're negative. All 50 of you are negative with just one test, right? So it's a very clever idea. He came up with it. And so these French economists said, look, we can apply group testing in this context. And then I called my brother, who's the provost of Cornell, but also a scientist. And he said, oh yeah, I did group testing for mice. I've tested 40,000 mice together, PCR group testing, where he took swabs of the noses of mice and put them together So rather than taking each swab and putting it into reagent and
yeah, I get it.
That, you put in a whole bunch of swabs from a lot of mice into one container and test the reagent of that in one test. So he developed this on his own. He had no idea about Dorfman's work. So anyway, it's been done for years.
So it's a multi-stage process, because if it's positive, then you know that at least somebody within that group has, then you can do further testing based upon that identification.
It's even more clever, because the way it works is you put it up in a matrix. So you take each sample and put it in both a column and a row. You're in a column and a row, and if your column and your row are both positive, then it turns out that we've identified with the group test which particular person is, with that particular protocol, which particular individual or household, if we're testing household samples, is positive. So there's a way of very quickly figuring out, even doing pooling, who's exactly positive. So
now, how would that work with human populations in cities or in businesses or schools?
So my brother put me together with, so I wrote like a bunch of columns of group testing. I wrote one with my brother. My first article ever was my twin brother. It was fun. And so then he put me together with an operations research professor at Cornell, Peter Fraser. Peter worked out a protocol with some kibitzing for me on how you could group test the entire country, the entire U.S. population, and you do it by household. So every household would send their swabs in a reagent with a cap on it they get the kits in the mail. They send it back in the mail to a lab, and then the household would be pooled with other households, and you would be able to test every household once a week. Since everybody is going to be quarantined together in a household, you really just need to know if the household is positive. And also, because the individuals in the household have a correlated disease, if you don't get the virus on one swab from one member, you get it from the other person. So that reduces the false negative problem. So anyway, we figured this out, that in a month, in Peter's formulation, that you could get the entire virus contained and killed, captured and killed within a month. You'd have the end of the problem. Now, this was all written up in April.
Hold on. The reason it's the end of the problem is because you will have, with very high reliability, identified the universe of infected people.
Yeah, and then you contain them. And by the way, the repeat testing, every household.
You can't have any leakage here. A lot of this is depending. The question I have is, how robust is the protocol to small deviations from it actually working as it's supposed to work? If you don't get 100% participation, if you get 98.6% participation, does the effectiveness fall by 1.4%, or does it fall by 14% or 24%? You see what I'm saying?
Yeah, it's very robust, because you really need, just to get this R naught, the number of people that one contagious person infects, you need to get that below 1. So if I'm contagious, if I'm infected, if I only infect 0.9 people, that's enough over time to eliminate this contagion.
This is the so-called R naught.
R naught, yeah. So that's all incorporated. He had built into his analysis very high false negative rates, much higher than we think is actually the case for this particular test. So there is a way that the president back in April could have organized the entire country to, even with people not using masks, not social distancing, we could have starting in April, had this entire thing over within a month.
By implementing a very systematic regimen of group testing to identify and isolate the virus.
Yeah. And then you would get a notification from the lab, and then you could take a picture of it, send it to your employer that you're actually negative, your household's negative. And
why has no one done this? If this is such a good idea, has anybody anywhere done this?
We have a president who thinks that the government.
No, I'm saying anywhere on the globe. Has anybody anywhere on the globe implemented the process that you just got through describing?
They've done some group testing in certain countries to a limited degree. They haven't done groups of 50. They haven't actually even tested groups of 50, except in some research. There's a study out of Harvard, out of the Broad Institute, where they showed that a group testing of 50 was very effective. There's another study in Israel, group testing of 50 even bigger.
The only point I'm trying to make here, Larry, is that if we could have nipped this in the bud in April, anybody could have done it, and nobody did. So that makes me think it might not have been so easy to nip it in the bud in April. It's not just a function of who's president of the United States.
Well, let me respond to you, okay? There's only one organization that I know in the country who's going to start doing group testing, and that's Cornell, because my brother has organized that through Cornell. So they're going to be testing students and using group testing to test students.
You know, I think we're going to do it here, too. I think I saw that in the memo where they were describing plans going forward, that there was some aspect of that would be group testing.
Let me tell you a little bit more about the group test. Just really, I don't want to spend too much time on it because there's this other idea, too, which is individual rapid home tests, but we'll get to that.
Well, no, we're just talking about the economics of COVID-19 mitigation and management and the use of testing information. So this is perfectly fine. We've got plenty of time to cover both fronts.
Okay. So anyway, wrote these articles. And then my brother and I were working with people at the White House, pushing them. Particularly, we're very interested in getting Cornell to reopen because it's, they're trying to get the universities in general, the economy back going. So my brother is pushing for group testing, and the FDA was blocking it because they're concerned that there's going to be dilution if you have too many swabs together. The negative swabs in the sample will have too big of an effect on the positive. You won't detect there may be one positive sample out of the 49 negative, although it's been shown that it is detectable. But they're worried about it, and their language in terms of what's allowed for testing precluded anybody actually doing group testing. So one of the answers to your question about why no country, including our country, has done this has been the medical establishment, the regulatory medical establishment in the different countries. And certainly in our country, the FDA was blocking this. So after weeks of interacting with people in the White House task force and even beyond that in the who are kind of involved with the FDA, we got the FDA, the people in the White House and other officials in the government, with some pressure from us. I don't want to say that we were responsible, but we certainly kind of started things rolling. The FDA changed the language and they put out an FAQ that allowed for group testing for surveillance purposes. And then you saw a slew of articles being written in every outlet, and you heard Dr. Birx and Dr. Fauci talking about group testing publicly. So now, again, so right now we're in a situation where group testing is much more accepted even by the FDA, and where the president today could organize this effort and we could have the thing ended in a month. There's a protocol right on Peter Fraser's website. It says exactly how to do it and that it will work. So we have the potential to do it. We have an ineffectual president, a president who ideologically speaking won't do anything that, even though this is voluntary, we don't need to compel people to be.
I don't know why this has got to be about who's the president, Larry. I mean, for crying out loud, you have a good idea. Hold on, let me just make this little speech. You have a good, practical idea.
Yep.
Group testing is a way of tracking down quickly and isolating and preventing the further spread of the virus. And you have laid out a protocol. This is a good idea. Frankly, I think it's the first time I'm hearing it. And I'm a reasonably well-informed person. I don't know everything, but I'm a reasonably well-informed person. So the idea that it's Donald Trump's fault that we're not doing this, come on. That's just politics. And I'm not trying to defend Donald Trump. We should have a better president. I agree with you about that. But you cannot be sure that if Joseph Biden was president, we'd be doing group testing because nobody ever even heard of it.
Well, hang on.
So why don't we stay focused on what it is we have to contribute to the public conversation here, which is not another barb directed in an election season at a partisan opponent, but is a scientific disquisition about the economics of COVID-19 control. Why don't we do that?
Hey, Glenn, you're when you went into that little wrap, you had your eyes closed. I was about to get up and try and close this door so it's less noisy. My wife's taking a shower. Okay, so give me a second.
Okay.
Well, we don't want to blame the president for things that he was not able to know about, but you got to recall that we're in a context here of my talking to people, my brother talking to people at the White House who were on the task force who were talking to the president. Okay, so if they didn't transmit this idea. And certainly I was transmitting the articles I was writing. I realize you don't sit on my website and watch everything that shows up. But I wrote 5 articles, and the last 3 were talking about this protocol.
Well, here's what I'm saying, Larry. What I'm saying is the formulation of public policy is a messy Byzantine affair. I'm saying good ideas get overlooked every day by bureaucracies that because of the way that machinery works, the memo didn't get to the right guy's desk at the right time and the decision didn't get taken. That's what I'm saying. I'm saying we could reproduce this story. Good idea about an important public policy question that never quite made it to the top of the pile in dozens of different applications. And I'm saying not a single one of them would be telling us anything important about the virtues or the efficacy of who's president of the United States. That's what I'm saying. And I'm saying that I personally, Glenn Loury, grow weary of the way in which Trump, and by that I put it in inverted commas because I'm not just talking about the person, I'm talking about the phenomenon or even the era, insinuates itself into and corrupts the capacity to actually stay focused and be constructive in the things that we're saying. That's what I'm saying.
Okay, what I'm saying is that this man has responsibility for not enacting, because he set up an atmosphere inside the White House that testing is taboo. The testing is something that is a big negative. So people inside, I'm quite sure that they're quite afraid of sitting down with him and suggesting something that would be the government sending testing kits to everybody in the country. That's somehow verboten. So I think he bears responsibility. I think we'd have probably 100,000, maybe at least 50,000 fewer deaths right now had he enacted. He had a different attitude about testing, and we had enacted this protocol back a couple months ago. We could enact it tomorrow. Now there's another way but let me just be clear to your listeners, your viewers here, that what I'm proposing with weekly household group testing, and I'm also going to propose rapid home testing as another alternative way.
And I want to talk about that.
Let me just be clear.
Yeah.
The households don't have to do it. They could refuse to do it, but they wouldn't get any certification in the mail or by email that they were negative. And they wouldn't be able to send a picture of that certification to the employer, to the restaurant to make a reservation, to the school to let their kid get into school. So if we had this information, it goes back to what you started talking about at the beginning about the nature of this conversation, this particular conversation, that we're dealing with a public goods problem and an information problem. So we need to have, if people had the information that they actually were negative, tested negative, then the market would automatically say, look, you can't enter here unless you have a mask, but you also have to send me an email with a picture of this, or a text with a picture of this a green stamp on your test result that you're okay. If it's a red stamp, you have to stay home. You can't come to my restaurant. You can't come to my school. You can't come to my university. You can't come to my business. With that, we have people. Everybody in the country, every household will have a strong incentive to want to get group tested. Or now let me just switch gears and talk about rapid home testing.
Hold on just a minute, Larry. I want you to talk about rapid home testing. I just don't want the point to be missed, because this is I think one of the things that economics has to contribute to the conversation. The word public good, so not everybody knows exactly what it means, but we're just saying we're trying to produce an outcome here, containment of the virus, which requires all of us to take actions, which it might not be in the interest of any one of us to take just based on our own well-being, okay? So we need to kind of effect a cooperative thing where people do something even though it seems like it doesn't pay for them. So we need to make it pay for them. So information plays a really important role in that, because if I'm running a business and people are afraid to come in there because they think other people might be sick, I have an interest in knowing whether or not people are sick. And if people have the information that they can provide to me, I can make sure my other customers know that they're not going to get sick, so we can solve this problem. But unless there's a reliable way that a person can identify whether or not they are sick, that they can then show to other people, none of this kind of cooperative benefit is going to be realized. So that's the role that the kind of testing that you're talking about is playing in solving an important information/public goods problem.
Yeah, exactly. So it's really simple, and it can be achieved by getting a notification that you've been tested, and here's your result, either via group test, but you could also have testing via rapid home tests. We have pregnancy tests, which people can instantly see whether or not they're pregnant. So what about a rapid home test where ideally you could lick a piece of paper and it would turn green if you were negative for COVID and red if you were positive for COVID?
Does that technology exist?
There are companies now that are very close to having that technology. You have it in within a month or two. I know, and I wrote about this with Michael Mina, who's probably the top one of the top epidemiologists at Harvard, in the New York Times. You saw that op-ed about 10 days ago came out. It's posted at kotlikoff.net under columns. So Michael had been in touch with different companies who are developing these rapid home tests. One of the companies is called Sherlock. It's based in Cambridge. It's got one of the founders is Jim Collins, who was a BU bioengineer, moved to MIT. He's probably the top bioengineer in the world, as far as I can tell. He's a terrific guy. He's honest as the day is long.
He's been at BU forever, hasn't he?
But he actually moved to MIT about 10 years ago.
Oh, I see. Okay.
He's just a leader in all kinds of these kinds of bioengineering initiatives, including vaccines. And so anyway, so I've talked to Jim and the people like Sherlock. They've got something that will come along within a month or 2 or 3 months. It certainly needs government funding to get it to happen quickly and to roll out these tests in large numbers. But there are other companies. There's probably another 20 out there. So what the government should be doing is rapidly putting together an expert panel and deciding which companies to invest in and pay them to produce enough paper strip tests or rapid home tests, depending on how it's actually delivered, for the entire population for a year. And they should do it in a redundant manner, because they don't know who's going to win in terms of this competition of who's going to develop the best test. And there's nothing wrong with somebody using 3 different rapid home tests at the same day, because that's going to reduce the false negative rate. None of these tests are going to be as precise as the PCR tests that we all know about. But if you do it every day,
hold on. Let me just slow you down, man, because there's so much. I mean, there's this large question of how do you incentivize a research competition in order to solve a problem that has high public value, and you suggest parallel kind of contests with the government seating and multiple investigative teams. But I want to ask you a question about the interrelationship between different fronts in the technological response to COVID-19, one of which is testing, and the other of which is therapeutic, and the other of which is preventative vaccination. How valuable would a universal testing regime, everybody every day, be in a world in which there were much more effective therapeutics and a workable vaccine? Would the Manhattan Project crash effort that you suggest in the area of testing be kind of competing with a crash effort in the area of vaccine in terms of public money and public influence? Do you see what I'm saying? How do those 2 different projects are they complements or substitutes? Do you see what I'm asking?
I would say in some way, I mean, in terms of, we don't know if the vaccine is going to work, how many they'll be able to produce. we want to diversify the risk here by investing in lots of different things that are going to save the day. And rapid home testing, group testing, which would require developing robotic instrumentation at the labs. So there's some startup time on that too. Treatment, better therapeutics, all of these things we should be investing in. They're a drop in the bucket in terms of money compared to giving out $1 trillion at a pop in different congressional bills. So we should have been doing this months ago. We should certainly be doing it today. There's no guarantee that the $2 billion that the government just spent on Pfizer will work in terms of the vaccine. God help us that it does, but there's no guarantee. So we need to invest. When they worked on the Manhattan Project, there were something like 10 different technologies for how to actually make the bomb explode and how you'd actually get the reaction to occur without it dissipating or spreading. And they just invested in all kinds of different options until they figured out which was the best. And then they let the other ones go. So that's what we want to do, reduce the risk that we don't end up with an answer. And just on the issue but another point, okay, so we need a Manhattan Project. If the president doesn't read the New York Times 10 days ago, everybody else in the White House did read that article. He should know about that. I think that they're actually working on trying to fund. I think that he will get behind. It's not my strong hope that the president will get behind rapid home tests because it may feel less invasive for some reason than group home testing, organizing that. But having the government send every household a rapid home test for every day for the next year, that's just what we need because, and the test has to be sufficiently precise or in order to make sure we don't get a lot of false positives.
Are you making light? I'm sorry, and I'm not being critical unnecessarily. I just really want to ask. I mean, the logistics. A year's worth, is that what I'm understanding, of tests for every household that they can use every day, every person?
Well, think about the
how does that get done? I mean, just physically, how does it get done? Is it the U.S. Postal Service that's delivering these things?
Service. You could say, we're talking about strips of paper, potentially just a piece of paper, a small piece of paper that you would lick in the ideal setting. And
well, why not hand them out like they do condoms in some dormitories? Or, just anybody can put their hand in and pull one of these test kits out of the bowl anytime they walk into the CVS.
So they would be distributed in lots of different ways, but I think certainly getting them to people that maybe are not mobile or disabled through the mail is likely, maybe one of the.
So we're going to need hundreds of billions of these tests.
Yeah, well, we need to also provide them to the rest of the world too. We don't, that's also.
We're going to need trillions. We're going to need trillions of these tests. How many factories? How much? What about the raw material? What's the supply chain look like? What are the logistics? What does it compete with? Do prices of certain things get bid up through the roof because you're trying to do all of this tomorrow? Just asking. Have you thought it through?
Yeah, I think it's really cheap. I think we're talking about potentially $1. Well, right now they're talking about potentially getting down to $1 a test per person. So it's like $365 for you. Can the government afford to give you $365? Yes. And
well, that's where you would get it down to. I assume it's 10 times that now.
Even right now, they think it's $1 to $5 what these tests would cost. And my guess is that with learning by doing it, we get down to 10 cents a test. So this is not, we built a B-64, I think, what is it, B-64? We built these bombers. I'm not sure it was B-63, B-64 bombers. No, it was B-23 bombers in 64 minutes in World War II. That's what it was, B-23 bombers. And some bomber expert is going to tell me I'm crazy here, but this is what I read a while back, that we were able to build bombers in 64 minutes. We were able to build cargo ships in 4 days in World War II. So we can work this solution. Now, here's one of the big impediments is the FDA in all this. The FDA has been championing the PCR test, which is a great test. It's extremely accurate, but it's very expensive. And we've seen that it takes time to run it. And now people are now having to wait for 2 weeks to get an answer. So this test, this fantastic test that the FDA loves, is basically useless in our country.
They try to do the FDA's job for them. What are their incentives and motivations? Do they simply not know what they're doing, or are they being paid?
I think the FDA does not know what it's doing. I think the FDA should be. I think they should be taken away from this task of approving testing for surveillance for trying to capture and kill the virus. They're focused on a perfect test for a single patient, so the doctor knows exactly the most information about that patient. So having the world's most expensive and slow, perfect test that can't be used for the entire population, that might be great if you got, Bill Gates who can afford to pay for that test, and your goal is to make sure that Bill Gates is healthy or sick, and you treat him the best way possible. But if you're trying
So you're saying that the culture of the FDA, which has developed in its role of guarding with drug innovation against the possibility that an ineffective or harmful treatment would get widely disseminated, that's how they understand their role. But we are now in a pandemic, and the risk-benefit calculus is very different with respect to the regulatory function. What should trigger disapproval in this environment should be much, much, much more higher threshold than what would trigger disapproval in a conventional drug regulation environment. And as a consequence, the FDA is now an impediment to effective public health overall. Is that what you're saying?
Yeah, these companies that are developing these rapid home tests are actually afraid of the FDA, because if they send let's think about a hypothetical company that develops a test that has a 60% false negative rate. So only 40% of the time when you're actually positive will you be positive. But let's suppose that a never diagnosis calls you positive if you're actually negative. So it has a zero. Okay. So as a zero, let's suppose that exists. The FDA would reject that out of hand. They would say,
I get
this is a terribly insensitive test relative to the PCR test, and so they would say, we're rejecting this. We're not allowing it. But think about it.
I got it, man.
Here's another thing, Glenn. If you took that test every day for 5 days,
it'd eventually show you positive.
The probability that you're always going to flip heads.
Oh, I get it. 0.6 to the 5th power is a small number.
Yeah, or 7 days. And also, you can take it many times in a given day. Because the way the virus works is you have very low load when you catch the virus, and then it grows exponentially. So these tests can be very inaccurate at low loads, but highly accurate at high loads. So that even 40%, 60% false negative rate could go down to 5% with very high loads, which happens when you get contagious. Even though you may not have any symptoms, you will be contagious, and you will have billions of particles. You go from 5 molecules of virus in your particular milliliter to billions within 4 hours. It can happen that rapidly, from what the Michael Mina, the epidemiologist at Harvard, told me. So,
has this been written up? I'm sorry to interrupt, Larry, but I want to underscore this point because I think it's such a profound point. The regulatory imperatives of drug approval are very different with respect to reaction to the pandemic than they are with respect to ordinary day-to-day medical regulation business. And your example of even a test with a high false negative rate ought to be approved because the net effect of using it in the practical way would be to significantly mitigate the disease, and that's what we're trying to accomplish. I think it really illustrates this point. So what would need to change in the chain of authority because these things are all, the FDA is not trying to tell the antitrust people what to do. The antitrust people are not trying to tell the environmental waste site people what to, you see what I'm saying? How would you govern environmental regulation that would be flexible enough to accommodate this point that you're making?
Well, let me pick on one particular word, and I'll come back to answer your question. I pick on one particular word that you said, the objective. They've got the wrong objective function at the FDA. They're trying to find the perfect diagnostic test, whereas we want to capture and kill the virus. That's our objective here. We're fighting a war with a gun when we have a cannon that we can bring out. Okay, so if the objective is to detect the virus when it's got a high load, when people are contagious, and never miss it, that requires an everyday test. That's why you want to test everybody every day. And certainly when the load gets really high, you will get it from these inaccurate, less accurate tests. Whether you get it the first time you take it, do the test, or the second time, there's nothing that says people who might feel that they're worried, they have some kind of symptoms, they start to sneeze or have a temperature, a low-grade temperature, they could do 5 strip tests in the same hour. They don't have to do it 5 days in a row. They could do it 5 days in a minute, 5 times in a minute, because it's so cheap. You're sitting there, you've got all these tests in front of you. Right there, you just pull it off.
Let me just note, this is what a critic would say, and your hypothesis that the false positive rate is 0 in your example is extremely important. Okay?
Yes,
if that false positive rate were 0.05, we might have an issue. You know what I'm saying? Because the implication of the information is so very different in the case of a positive and a negative. And the positive is going to elicit all kinds of responses, which will be very costly if it turns out to have been false.
The FDA, to give them their due, the FDA is legitimately concerned about that as well. That people, but the instructions on these rapid home tests would say, if I were in charge of it, they would say, look, if you are positive on this rapid home test,
take it again.
Well, take it again, but if you're serially positive, if 5 out of 5 are positive, or some number out of 5 is positive, go to call your doctor,
a more reliable
get
test,
a PCR test, and that's where this can be much better for diagnosis.
I understand
that most people, according to the CDC, 9 out of 10 people that actually get the virus never get the PCR test. So most people are not being diagnosed. But with this rapid home test, where you get a signal that you actually are positive, now you can go off and get the test, and we won't have everybody trying to get the PCR test as is the case now, where everybody's jammed up trying to get the PCR test, and there aren't not enough capacity to do it, and it takes 2 weeks to get an answer.
I see. So I want to raise another aspect of this thing, because I think these are really important.
Let me just answer your initial question, though, which is,
sure.
If I were in charge, I would move the FDA out of this task of approving testing and have it be done by the CDC. For the purposes of containing and killing the virus, I would make this a CDC responsibility, because they have, I think, the right objective function, where the FDA has the wrong objective function. And somehow...
Well, now, what about vaccine approval? Is the FDA going to be the last word on that?
I think that's a medical issue. Yeah, I think the FDA should be responsible for that, but not for...
But testing's a different story. Okay.
Testing's a different story, because...
No, I wanted to get you... I'm sorry, go ahead. It's a different story because...
Center for Disease Control, right? That's their job. Yeah. The FDA, Food and Drug Administration, they're trying to make sure that nobody ingests something that's going to poison them.
Actually, the distinction between disease control and Food and Drug Administration is kind of perfectly captured by the names of the agencies, isn't it?
Exactly. Yes. Right.
But I wanted to get you to talk a little bit about the economic implications, because I can envision a world where if everybody could identify that this morning at 8 a.m. with a time-stamped image, I tested negative, and they could send that in with their reservation request to the restaurant. Even you and your lovely wife, Bridget, would be willing to dine in that restaurant with other people at tables nearby, because you would have an ironclad proof that you were safe. And I just think that could revive the entire restaurant industry, couldn't it?
It could. It could get all the businesses, the entire country back up on its feet tomorrow. Well, it's going to take at least, if we have these rapid home tests that we're describing in our hands today, it would probably take the economy 3 weeks to get back on its feet, literally that fast. Because within 14 days, we would find out essentially everybody who was positive, they would be staying home. They would be informing their doctor. They would get a PCR test that would confirm what they found. And if they were positive, they would be staying home, and they would not be infecting people outside of their home. So we would have we would win the war. If the president wants to win the war, he needs to use the right ammunition.
This could work at sporting events. It could work at meat packing plants. It could work at political conventions. It could work at economic seminar rooms. We could be back to life again if only we had the information and the way of verifying reliably the information. Right. We are economists, after all. I think we got our fingers on something important here, Larry. Or I should say, you have your finger on something important, and I've got a free ride because you're my friend.
Well, I mean, we're all, I learned some stuff from the French guys. We're all talking about this collectively, economists. Anybody who's kind of just thinking about this without some kind of blinders on, that I've done the FDA seems to have blinders. They're not looking at the big picture. They don't have the right objective. So they are blocking, and these companies are scared to death that they're going to be like Abbott Lab. They'll be treated like Abbott Lab, who came out with a 5-minute test and then was criticized, I believe, by the FDA for that their test not being as sensitive as the PCR test. But if you can get an answer in 5 minutes, you can get another answer in 10 minutes later or 2 days later. So Abbott Lab got burnt. These other companies that are smaller don't want to get burnt because they'll be out of business, because they'll have on the web for the rest of their lives the FDA condemnation. It's that information problem as well that needs to be dealt with.
That's also interesting. The rejection is a stigma. It's a reputational hit. The company doesn't want to take the risk, and so it doesn't even venture the request for approval. So you're shutting down innovation. That's an interesting problem.
These companies have like 20 things they got going, and they figured, for humanitarian reasons, we have to work on this. They start figuring out how to do it, how to get that rapid home test. It's not as sensitive as the PCR test, but over a week, if it's a PCR test that nobody's taking, it's much more sensitive, even 40%. But if it's 40% every day, the probability that you're going to be, it's going to.
Like I said, 0.6 to the 5th power gets to be a small number. Okay, shall we call it a day, Larry? Do you got something else you want the Glenn Show audience to hear from you?
No, this has been great.
I think it's a nice, little package here. The economics of COVID-19 management, focused on information and testing, the power of group testing, and the revolutionary implications of personal testing on a frequent and verifiable daily basis. This could be done. Smart people are thinking about it. Larry is one of them. And we're grateful for you coming on the Glenn Show, Larry.
Well, let me just close with one little tidbit.
You can have the last word.
About economics. And, I'm not trying to connect me with this economist, but I was reading a book about by accident, about the making of the atomic bomb. It was a Pulitzer Prize book about the entire history of how that was developed. And interestingly, Einstein wrote this letter to the President Roosevelt, that the Germans might be developing an atomic bomb. And it was sent through through circuitous route. It ends up in the hands of an economist who's actually a personal friend of Roosevelt. And it takes the economist a month to get in to see Roosevelt. He doesn't send a letter from Einstein. It takes him a whole month to get in to see Roosevelt. And then he spends an hour and a half talking to Roosevelt about old times. And he finally gets around to the topic. He never shows Roosevelt the letter from Einstein. He explains to Roosevelt the problem. And at the end of this, Roosevelt gets the point that the Germans are going to develop it faster than us unless we get on the problem, on the issue. And then he leaves the letter behind, from what I understand, in the book. So what's the point here? Well, the point is that information can be transmitted in different ways, but the main thing is the information is the right information. And then Roosevelt took action. So we're now at a point where we have to take action. However the message gets to the president, however it gets to Vice President Biden, if he becomes president, there are ways out of this hole that we're in. There is a way to win this war. We have to start fighting it with real ammunition.
Okay, Larry. Well said. Again, thanks for coming on the Glenn Show.
My pleasure.